I'm very pleased to introduce Sara Craven, a good friend and colleague at UNFPA, who's going to moderate our first panel. Sara.
Thank you, Nomi. I'm so happy to be here today. This is just what a great room of advocates and program providers all together. This is very inspiring for me to be here. So I'm just back from New York. I came in quite late last night up in UNFPA, where we are quite focused on the first quarter of next year, looking at the CPD that's coming up. We are looking at the 20th anniversary of the ICPD and our report that's going to be issued, and we're looking at the post-2015 framework, and all of those conversations are focused on data. So this panel could not be more timely, I think, not just for the work that we're going to see happening at the UN global level next year, but of course also the work that we are continuing to do here in an increasingly shrinking funding climate, how we have to be sharper and even more focused in what the stories we're telling about why these are programs that need to be funded robustly and supported. So data is critical to that, and we have three experts, one on her way, one who has arrived, but we're not going to make Ellen go first because we're going to let her get her coffee and take a deep breath. In your packets you have your bios. I feel like we all know each other, and it's just terrific to have this group assembled today. But I will say I'm going to turn it over first to Amy Ratcliffe, who's with PSI, where she is part of the impact planning and improvement team. No, that was what she was doing. That was Gates. Now she's the senior technical advisor for metrics for PSI. So we're going to turn it to Amy, and then we will hear from Valerie DeFillipo, who is the executive director of FP 2020, and then we will hear from Ellen Starbird from the Office of Population at USAID. So I'm going to just let each of them speak. Each of them is going to have about 6 to 8 minutes, I believe, because we wanted to have an opportunity to hear from you in the audience and to engage in Q&A. So with no further ado, I think, Amy, they wanted you to sit. Is that
just grab the mic and then you can
Okay, grab the mic.
Oh,
there you go.
Okay. And I'll use your time.
Good, thank you. So yeah, thanks very much for including PSI in this. I think PSI has a reputation of measuring results, and one of the things that we're really trying to encourage within the organization is much more use of results and really linking data to decisions. So this was very timely for us because it's something that I'm really trying to garner best examples from within the organization. So I'm pleased to be able to share the material that I brought with me today. Just an overview quickly of what PSI is. PSI works in now 66 developing countries. We are not just a family planning organization, so there are over 60 products and services that are provided by PSI, both in terms of product distribution and service provision. We're actually, so the health area key that's here shows the range from HIV, child survival, malaria, reproductive health. We also have work on respiratory illnesses, and we're looking into NCDs. So family planning is one piece within this broader context, and that does allow us lots of opportunities to do integrated services. So this brings up the health area slide a little bit easier to read. And I can also add diarrheal disease to that. This shows the network of family planning service delivery for PSI, and these are primarily social franchises where we support providers. And right now there are 23 franchises, 20 of them provide family planning services. So I wanted to highlight a few examples of ways that we use data for decision making within PSI, and these are all examples from family planning so that you can see kind of the practice and also some of the limitations that we have. I've chosen these 5, the family planning method mix. I'll talk a little bit about our new management information system, quality assurance audits and adverse event tracking. We'll talk a little bit about how we keep our eye on the market and looking beyond our own service provisions so that we can help sustain or achieve healthy markets. And also I'll talk a little bit about some of the information we get on exit interviews, which is really pertinent to our equity tracking. So as I said at the beginning, PSI has this reputation of using and tracking measurement. To the extent, and I joined PSI 2 years ago, to the extent that every month they have a meeting at the corporate level with the executives and directors to look at progress in the level of detail that I'm showing right here. And I don't know how much of this dashboard you can see. I included it primarily just to give you a flavor of the level of detail that we're looking at. But on a monthly basis, we look at progress in DALYs averted throughout all of our interventions. This is the disability adjusted life year, and we calculate impact in using that measure because it allows us to look across all of our interventions and standardize, if you will. Now, that metric itself is the core performance metric at PSI, so that's what the corporate and the board really keep their eye on. But the CYP better captures the family planning progress. Now, at the corporate level, the couple years of protection that's been around, I shouldn't say since the inception of PSI, but it's certainly historically very important. It doesn't get to the nuances of the things that we really want to promote now. So we have a new metric that is also included in this monthly meeting. Every month we look at the country's method mix. And so we are promoting 75% of our countries at, across the board, 4 or more modern methods with 1 long-acting or permanent method within their set of services that they provide at the country level. Now, the reason for this is obviously choice and having a range of different options for women, but the long-acting method is also something that is important to some of our donors. And so it's something that we're really trying to get across the board. But this shows you the mix right now of countries and where they are. Right now we have about, I think it's 23 of our 57 countries, that number might be quite a little bit wrong, are at 4 or more modern methods with 1 long-term method. So we use this to encourage a range of methods. And the data that we look at is the number of modern methods that are provided in each country. The decision that we make is at the corporate level, tracking to promote this at the country level. So it's really at the country level that we expect an action to take place. The decision would be at the country level. So this is an example of something that we're looking at corporate and then country by country. The management information system is, we're investing right now in getting a standard MIS, and it's based in the DHIS2, which is a public access platform for management information systems. And we're promoting this across all of our countries and programs. So right now we're rolling it out within one of our programs, and we'll be getting to the point that we use it across all countries. We also use this for reporting services to CORE. And there are 3 examples here of bits of information that we can use from the MIS. One is client-level records, which allow us, again, just as one example, to look at age and marital status of users so that we can actually, at the program level in the country, they can be tracking the proportion of users that they're getting who are youth, and also those who are young and married or young and unmarried. So that if that's something that they can work with unmarried women in their country, they're really able to push that and make sure that they're reaching youth and those who are at need. The next is aggregated previous contraceptive use, and this is something that we are looking at with looking at the percent of users who are new users with the idea of promoting outreach to new users. And this is an interesting one because the FP 2020 indicator is really about adding additional users and that demographic trend. But at the program level, it really gets translated to new users. I wanted to just share the clinical quality assurance standards. So this is something that we track through this feedback loop with training, monitoring, and evaluation. And two things that come out of that are the adverse event tracking, where we can tailor training to individuals to make sure that we're addressing systematic issues, and also using the quality assurance audits to resolve findings immediately and have 3 months to implement to improve quality. I also just briefly want to share the market access and performance surveys that we do. These allow us to look at outlets and at the provider level understand what type of providers we're working through, and also then to look at the proportion of those providers who have our products and other products of interest. So we don't just stay focused on the products that we have. And this allows us to look more broadly at the market itself and help adjust, as needed to encourage other brands. So public, private, and social marketing. And one of the things that I'll just briefly show right here is the wealth quintiles as something that we want to make sure that we are addressing the correct wealth quintiles. And in this case, what you see is that the richest were the ones who were actually accessing our services most in this country, and that's something that we need to really reconcile. And this was a finding that directly caused, there's decisions and actions immediately when you find a finding like this. And I will finish there. I just wanted to give you all a taste of the sort of things that we're looking at. The wealth of information that we have is great, but the key is for us to get that to decisions and program improvement. Thanks.
Hub for this collaborative partnership. And so focusing on measurement globally and nationally enables the world to track progress and be accountable and problem solve to improve performance. I want a note about accountability. I think accountability is far more than just naming and shaming commitment makers when they fail to follow through on their promises. Accountability is really an aspect of justice. It invokes the expectation that institutions will respect the needs of all the people who are affected by their actions and will operate in a way that promotes equity and inclusion. Because bottom line, it is to the millions of women and girls and their families out there that we are to be held accountable. Those are the bottom line of the people we need to serve. So the measurement plan really allows countries to be better supported by global actors. That's what we're really hoping. We don't see a measurement plan where the global community sits there and measures the progress of countries. It's more like, let's get a plan where the global actors can help the countries in their own desire to measure their performance. So the way that we see it is the countries are in the driver's seat, building their plans, with data showing progress against goals feed into the FP 2020 website. We are going to try to provide that information so that we are accountable to the overall global architecture, like the Every Woman, Every Child, that we're accountable to the 18-member reference group of stakeholders who oversee the directions of FP 2020, and that we have the FP 2020 working groups and task team reaching out to our wider stakeholder community to share the data so that you can use it either in your program design work or in your technical assistance or in your advocacy with governments both here in the United States and governments around the world. And we think that because we're working so closely with the donors governments are another lens through which the data can be diffused that also helps to improve performance at the country level. We do this through a performance monitoring and an accountability working group that has about 20 members across a lot of different stakeholders. Again, the working groups will change composition every 2 years, but the PMA is really responsible for, again, monitoring the progress and strengthening accountability. We went through a process last year where we did approve at the September reference group meeting of FP 2020 initial core set of indicators. This is a really important. As I was saying, I think to Margaret Noyes on break, I had never understood how contentious and political indicators were until we went through this process. I have a deep and abiding respect for the feelings and around the indicators. I think I learned that, it's deciding what's going to be measured is really also what's deciding what is going to be given visibility. And so, this is only a beginning work in progress. They set out a conceptual framework for the indicators that really looked over at a certain number of dimensions, and those areas were in the domains of enabling environment, process, output, outcome, and impact. They really tried to get at least one indicator per domain, and to make sure the indicator was relevant to the domain and methodologically sound. And that meant based to the greatest extent possible on existing definitions and standards and with documentation readily available. They wanted, another consideration that went into selecting these first core indicators that was that the data was currently available. The indicators were also, the selection of them were informed by the Rights and Empowerment Working Group that set along a number of recommendations to ensure that there would be accessibility and quality dimensions, plus agency accountability and autonomy represented in the measurement, the first measurement agenda. Some of the recommendations have yet to be taken on because we simply lack the data, and that is a part of our ongoing work. And also attention was placed on indicators that had important global platforms already, so that we were aligning with the existing platforms like Every Woman, Every Child. We went back and looked at the ICPD Program of Action, the Maputo Plan of Action. We looked at PMNCH and the WHO's indicator development process on health and rights. So we ended up with core indicators. We have some new indicator development, as I said, that will be going on. And the one I wanted to mention really briefly is the Policy Environment Composite Index. I'm not going to pretend that I am an expert in this area, but I thought this might be of particular interest to advocates because there's work going on to try to develop a further, clearer policy environment index. It's going to be, there's a meeting going to be going on in January, and they're going to be looking at how they can push that forward, looking at if there's an existence of an action plan, service guidelines, and a quality care monitoring system. We'll keep you up to date on that and share that information with you. Just to say that if you look at the accountability work that we're doing, to say out of the 74 new commitments that were made to the Every Woman, Every Child, 34 of them were from the London Summit, and so global political action can really instill a change in the way that people relate to family planning and to the issues that we're working on. And then finally, I think this is a great example, and I like to bring this up all the time. FP 2020 is only as good as its partners are. And I just want to commend the Kaiser Family Foundation because in and of themselves, they decided as a contribution to FP 2020 that they would begin tracking donor disbursements. And so they did so and provided that to us, and it's a beginning process, and they're going to continue to do it and refine it, and we are beginning to get this data. It'll be available to all of you. So I'm happy to answer other questions, but want to stay on time. Thank you.
So good morning, everybody. So my first lesson learned of the day is don't let Google give you directions to walk someplace or walk with friends. So I think everybody in this room knows that USAID has long been the leading bilateral donor of family planning assistance internationally. We're coming up on our 50th anniversary of family planning assistance in 2015, and we've seen incredible progress over that time. Modern contraceptive use in the 27 countries with the largest USAID-supported programs has increased from under 10% to 37%, and the number of children per family has dropped from more than 6 to 4.5 over that period. Our programs have adapted and improved over the years. They change with the country conditions, and every change and choice we make, we try to think out very carefully and have evidence at the base of it, to analyze that evidence and use it to back up our decisions. So I just have a few slides to give you a few examples. We assess the effectiveness of our interventions by looking a lot at trend data, particularly data that come out of the DHS. And for family planning programs, we look principally at that level at modern contraceptive prevalence, improvements in birth spacing, and age at first birth, all of which are measured through the demographic and health surveys and also through the CDC reproductive health surveys, which, by the way, if anybody has tried to find those, they're largely for Latin America and Eastern Europe, and they have been for years quite hard to find because they haven't been archived the way the DHS data have been archived. They are now all available online, and you can access them that way. So in addition to monitoring the progress in our programs through these international data, we also use evaluation findings to inform decisions, improve program effectiveness, be accountable to stakeholders, and support organizational learning. Research tests the effectiveness of possible interventions and is used to identify high-impact practices. Pilot studies and introduction studies test the effectiveness of interventions in specific contexts or countries, and those that best fit are the ones that are selected and scaled up. So let me give you just a few examples. At the local level, we have seen the impact that data can have in influencing change. Through the USAID IDEA project, run by PRB, partnered with the Family Planning Association of Malawi to roll out an engaged presentation called Malawi Investing in Our Future Now to traditional chiefs and local communities. Those of you may have seen other engaged presentations. There are some very good ones around the demographic dividend. This is the same idea, but at a different level and for a different audience. So far, just over half of the 28 districts in the country have been reached. And as a result, the traditional chiefs have drafted bylaws on keeping girls in school and penalties on parents for early marriages and unintended pregnancies, formed advocacy committees, formed reproductive health committees, and requested a meeting with their local parliamentarian to discuss these issues. Furthermore, villages are now presenting the Malawi Engaged presentation in the local language to raise awareness to local leaders about health, population, and development issues in rural areas. Another example is the Wagah partnership and the costed implementation plans developed under that partnership. The Wagah partnership is a partnership of West African Francophone countries together with USAID, the Gates Foundation, the Hewlett Foundation, and the French government to raise the profile of family planning in West Africa, get resources allocated to family planning in West Africa, which lags behind the rest of Africa in terms of contraceptive prevalence and family planning use generally. And part of that approach is to develop broad-based, country-owned national family planning costed implementation plans that are aligned to the Wagah partnership commitments and to FP 2020. So these are concrete, specific plans for achieving national goals related to family planning over a fixed number of years, driven by data, and then data also driving the implementation of the plans. They detail the program activities necessary to meet national goals. They cost those activities, providing clear program-level information on the resources that are needed to implement the program. And then there's an advocacy day hosted by the government locally, where the government convenes donors and other in-country organizations to lay out their needs, what they can cover with country resources and where the gaps are, and invites others to contribute funding to those plans. If at the country level those needs can't be met, then there's a process of reaching out to the headquarters level of donors and to do additional outreach to raise that money. So in addition to the very specifics of what's needed to implement the program, they also include estimates of the demographic impacts, health impacts, and economic impacts of the family planning program. So these give direction to the National Family Planning Program and can help ensure that evidence-based strategies and programs that improve family planning access are available and funded. So far, 7 West African countries have completed these plans, and this costed implementation plan process is one that we're also looking at under FP 2020 as an approach for other FP 2020 donor countries as well. The next example I wanted to provide you is an infographic developed by our Deliver project, and it calculates the health impact of contraceptive commodities. So it's called Contraceptive Save and Improve Lives, and it was unveiled at the 2013 Women Deliver Conference. Features results that compellingly argue for contraceptive support to achieve critical maternal and child health outcomes. I think when you look at the DHS data and you look at reasons that women don't use, availability isn't usually one of the reasons that they mention, but in fact, if there aren't any contraceptives out there for women to use, then obviously they're going to have issues and around unintended pregnancy. So this graphic shows how the contraceptives donated by USAID alone in 2012, coupled with comprehensive counseling and services, were sufficient to prevent approximately 230,000 infant deaths and 15,000 maternal deaths worldwide. So we've used this infographic to generate awareness internally at USAID and externally, including advocacy efforts on the Hill. And then my last example is a partnership between USAID and AusAid in Indonesia through the Improving Contraceptive Method Mix project to conduct evidence-based advocacy and knowledge exchange activities. So the data on Indonesia show that long-acting and permanent methods are underutilized, and among women who want to limit births, more were using short-term methods than long-term methods. And data also showed that women understand the advantages of using long-acting and permanent methods and that there's an opportunity to revitalize the use of those methods. Baseline results also suggested that increasing training for private midwives and provision of IUDs and implants would increase uptake of these methods, which in turn would help decrease unintended pregnancies and improve women's health. At the local level, the results are being used for advocacy activities in 6 districts, and at the national level, they're being used by the government of Indonesia to formulate an action plan for improving family planning services. During their recent National Family Planning Summit, after reviewing the data, government and nonprofit partners committed to improving training for midwives to provide IUDs and implants to expand access to long-acting and permanent methods. So I liked very much some of the words in some of the graphics that Valerie was showing around how you can use data to problem solve, to improve performance, to be accountable, and to track progress. And I hope that these examples have given you just a little bit of a flavor of how we do that at USAID. Thank you.